All right, welcome everyone to this first MIDRC seminar of 2024. We're all ready to go with full enthusiasm. Before I start introducing the speakers and the topic, a little housekeeping. There will be a live Q&A session at the end, but please feel free to enter your questions into the Q&A during the talk so you don't have to scramble at the end to get your questions in. So the topic of today is deep learning of echocardiography for detection of myocarditis and cardiac injury related to COVID-19 infection. Now we'll have our main speaker is Kwan, and he may be joined by David Ouyang, and they're both cardiologists and physicist scientists. So this promises to be a very exciting seminar. So Kwan is a cardiologist and physician scientist within the Smith Heart Institute of Cedars-Sinai Medical Center. He received his MD training from the University of Washington, internal medicine residency at Johns Hopkins, and cardiology fellowship, advanced cardiac imaging fellowship, and a master's in MRI in medicine at Cedars. His research interests include clinical translation of novel imaging techniques, electronic health records-based research, and computer vision within multimodality cardiac imaging. His colleague, David Ouyang, is a physician scientist and cardiologist with subspecialty expertise in non-invasive imaging and technical background in programming, statistics, and deep learning. As a statistician by training, he has always been fascinated by how to understand, visualize, and interpret data. And his goal as an investigator is to have expertise in echocardiography and deep learning applied to medical imaging while leveraging clinically generated data to inform scientific discovery. His previous work has demonstrated the ability of convolutional neural networks to identify systemic human phenotypes that modify cardiovascular risk previously thought to be not apparent on echocardiographic images and precision phenotyping of cardiac function with higher precision than human interpreters. And with this, I'd like to give the word to Alan for his seminar.
Hi, great. Thank you very much for the introduction. Let me just share my screen here. Okay, hopefully everybody can see that. So thank you very much for being here today. I'm going to be giving a presentation that we call named Deep Learning with Echocardiography for Detection of Myocarditis and Cardiac Injury Related to COVID-19 Infection. Here's our disclosures. They're likely not relevant to this topic. So overall, our objectives for this brief talk will be to describe our motivating factors behind trying to identify myocarditis, and specifically the context within the COVID-19 pandemic, trying to identify this by echocardiography. We want to discuss in a little bit of extra detail our approaches to labeling within our data sets and how that bears on the overall approaches to deep learning and echocardiography. And of course, we'll present some results and extrapolation of future directions as well. So why were we thinking echocardiography and myocarditis? I'm sure that you all remember the COVID-19 pandemic, which took up a good 3 years of our life and actually was not that long ago. But during this time, early in the pandemic, there were multiple reports of COVID-associated myocarditis. In fact, this was sort of on the back of multiple reports of elevated troponin in patients who were infected with COVID, and those who had elevated troponin having worsened outcomes, then subsequently expanded with some cardiac MRI-related studies suggesting that there may be a higher prevalence of myocarditis in patients even without symptoms. I would say that the publication of these results sort of caused a significant increase in interest in folks who were infected with COVID, whether or not they had myocarditis. And as clinicians practicing during this time, what we found was this presented some difficulty. Basically, for diagnosis of myocarditis. Typically, there will be a clinical examination, echocardiography to see if there's any reduction in ejection fraction, and then sort of triage to more advanced techniques. For example, we may look at the coronary arteries using cardiac catheterization to rule out other causes of an elevated troponin, or we may perform cardiac MRI in order to more specifically look for conditions consistent with myocarditis, myocardial inflammation, and the sort. But because during the pandemic, most of these patients were on isolation, and anytime we took them to, say, the MRI room or the cardiac cath lab, we had to undergo a decontamination protocol, cleaning the room afterwards. This was something that was difficult to deal with, I would say. And this sort of bears on the larger presentation of myocarditis outside of the COVID-19 pandemic. Basically, myocarditis can be a challenging diagnosis. Oftentimes, it's diagnosed implicitly instead of explicitly, meaning that you rule out other causes of an elevated troponin or cardiac injury. And then only once that is ruled out, you may pursue further diagnostic testing to try and find inflammation. But oftentimes, if it's somebody in the appropriate clinical situation, say a young man with a recent upper respiratory infection who is complaining of chest pain consistent with myocarditis, you would just say, that's most likely myocarditis, even though the gold standard is technically an endomyocardial biopsy. So we thought that it would be optimal, since basically all of these patients get an echo, to try and predict myocarditis based on that echo in order to either more appropriately triage these patients or avoid having to send them through these advanced pathways altogether. We want to do this by using deep learning. And so this makes us consider what would qualify as a good deep learning model, specifically something that is clinically useful. And we can roughly break down the model into three different parts. So you have your labeled data set, you have the model that you pass the labeled data set through, and you have the prediction and the relevance of the prediction. Within the sort of initial design, figuring out the labels, having there be a specific clinical need, having at least biological plausibility that you could get, say, a myocarditis diagnosis from an echo, having a high volume of cases, and having reliable and accurate gold standard labels is important. As far as the model training goes, you need to make sure you're using an appropriate model with appropriate training specifications. And you also have to make sure that the model is essentially providing a clinically meaningful interpretation, meaning that in some cases, you've probably heard about specification gaming, where a deep learning model figures out a clever way to answer a question. For example, it's trying to identify pneumonia from a chest x-ray, figuring out which chest x-rays are coming from the ICU, and using that as sort of the marker, whereas we would want it to actually look at the pathophysiology that we're trying to identify. And then finally, for the prediction, we want it to mean something. Within myocarditis, does it mean something if we diagnose it? And then we want to make sure that it's robust and still performs well in different populations, which usually requires some form of external validation. Specifically within our problem, our model, our situation, trying to identify myocarditis within COVID-19. When we're talking about the labels, we've established, or we just discussed, a specific clinical need, that this is somewhat of a difficult clinical question, particularly in the context of COVID. And then I would say myocarditis, it's not super uncommon, but it's not super widespread. So it's sort of right in a sweet spot for something to work on identifying. We do think that there's the potential for echo to provide some sort of signal for myocarditis. When you're reading echo, this is going to be performed as a standard part of myocarditis workup, and people will often point out sort of increased echogenicity of the myocardium as a marker for inflammation or injury. And previous work in our lab has used echo to identify, say, serum biomarkers such as troponin or other imaging markers such as coronary calcium scores. And then we also want to make sure we have an adequate volume of cases, which, given our time span, we would expect that there would be an adequate number of myocarditis cases. Now, do we have reliable and accurate gold standard labels? That is significantly more challenging. So the gold standard remains biopsy, which is still not even a perfect gold standard because of sampling issues, tissue sampling issues, where myocarditis may be spotty and may not be captured by an endomyocardial biopsy, in addition to having sort of referral sampling bias, where only really, really sick patients typically will get sent to biopsy. As I mentioned, the clinical diagnosis, so not really a gold standard diagnosis, but a useful diagnosis, is often implicit instead of being very clear, being explicit. For example, if we're trying to diagnose a STEMI, we can use coronary angiography to look for a complete blockage of an artery in the heart. And then when we try and access large volumes of these clinical diagnoses, typically we'll end up doing sort of electronic healthcare, health record research-based approaches by using ICD codes. ICD codes may have essentially have their own set of challenges. Some ICD codes end up in multiple different areas of the chart. We've done internal studies to look at sort of the relative accuracy of these diagnoses, although we performed it in stroke rather than other disease processes, as this was something that we felt like we could be more sure about as far as the diagnosis goes. And we found that ICD diagnoses placed in billing areas were typically significantly less accurate than those placed specifically in problem lists and past medical history. One of the issues is that oftentimes, particularly in the billing context, people will input ICD diagnoses as a rule-out diagnosis. That is, they have a suspicion of a condition and they code that during their workup rather than having a confirmed condition they are recording. Then myocarditis specifically has some challenges in that acute myocarditis presents differently than convalescent myocarditis versus resolved myocarditis, and even other sort of forms of it. So chronic inflammation leading to, say, dilated cardiomyopathy may be within the myocarditis spectrum, and it's not really differentiated in most areas. We do have cardiac MRIs, which we leveraged for part of this. However, the structured criteria, which has to do with the revised Lake Louise criteria, is looking for abnormalities in specific biomarkers, imaging biomarkers. But these may overlap with other etiologies and still remain essentially somewhat clinically interpreted. Has to have a specific clinical context. As far as the model goes, we use the 2+1D sort of ResNet-based model, which is a convolutional neural network that allows for video inputs, so allows for spatial temporal analysis. We have some experience with this, as I mentioned, using echo to predict serological biomarkers as well as coronary artery calcium. So we figured that this would have a good chance of working. We use standard, I think, an 811 training test validation splits. We were in the process of considering other forms of external validation, though we'll discuss that a little bit further. And then we have some experience with using model explainability approaches to make sure that we're using a biologically plausible approach to predict labels. And then, like I mentioned, myocarditis, or at least the diagnosis of myocarditis, leads to different treatment pathways in young patients, oftentimes 3 to 6 month exercise restriction due to risk of sudden cardiac death. Subsets of myocarditis may benefit from immune modulation, although certainly not all forms of myocarditis. We planned on future expansion if the results were reasonable within our internal test set. So this is the overall pipeline I would describe using that sort of layout of a label, model, and application for our initial set of diagnoses, which was essentially ICD code based myocarditis. And in order to improve that, essentially the myocarditis ICD codes are placed in the chart. We have a specific date for it, which sometimes comes with a specified date of diagnosis. We also looked for patients who had a positive troponin indicating cardiac injury within certain time spans of the ICD code. And then we restricted our echo that we would use, that we would label to within certain time spans of the ICD code of myocarditis, meaning if you had a diagnosis of myocarditis in, say, 2019, we weren't going to use an echo from 2024 and assume that it was still accurate. We created a 1 to 5 propensity match data set of echoes, playing around a little bit with some matching approaches. And we leveraged our essentially our model pipeline, which includes pre-processing for size and sort of standardizing the images, as well as a view classifier, separating out analyses in apical 4-chamber parasternal long axis and apical 2-chamber images, which were put through that 2+1 DResNet model. For the most part, we have the most number of apical 4-chamber images, so I'll mainly be presenting data from that. That output a label for myocarditis for echoes, and then we had around, I believe, 1,000 patients who had a documented positive COVID test with an echo within 5 days, which we were planning on applying the model to and reviewing to see the potential accuracy of that if our model performed well. We ended up testing a number of different variations for those labels. So I mentioned echo within a given time frame. We tried out 30 days. We tried out 90 days as different approaches. And for the troponin, we included the possibility of troponin within 5 days of the ICD diagnosis, which is pretty short, as well as 30 days within the ICD diagnosis, a little broader, or just ignoring the troponin regardless. And then the different match approaches, we would match on age and sex. We tried matching on ejection fraction, as well as age restrictions of less than 50, since typically myocarditis patients are a little bit younger. So we thought that might be good to sort of restrict to that population. Sorry, I think there was something else. No. Oh, yeah. So the idea would be that each of these restrictions may improve the accuracy of our label, however, may cut down on our population. And essentially, we're just trying to find the sweet spot between label accuracy and sample size in which the model would work the best. And so for our best result, we found that echoes within 30 days of the ICD diagnosis, ignoring troponin, matched on age and sex only with no age limit, no EF match, seemed to perform the best. This was cut down to a relatively modest population of around 347 unique patients with a little bit over 1,000 total echoes. There are about 3 to 4 apical 4-chamber views per study. End up with a bit of a larger total data set, around 28,000 apical 4C images. However, after running this in our internal validation, the max AUC that we got was 0.7. Basically, all the other AUCs were in the 0.6 range, which was somewhat disappointing, I would say. So despite testing out all these different labeling permutations, we felt that the AUC of 0.7, particularly for internal validation, was insufficient. And the reason why is that, 0.7 is not 0.5, but we don't really have, I would say, a high degree of certainty that the model is not detecting other things, say reduced ejection fraction as a surrogate for myocarditis, or something that would not end up being clinically useful if it were applied. So thinking about the potential causes for why our AUC was not better, why our ability to predict myocarditis using echo was not better, even though we have this assumption of biological plausibility, it's possible that echo does not essentially contain the adequate information to diagnose myocarditis. As I mentioned, with ICD diagnoses, inaccurate labeling is always a possibility. And those were sort of the two most likely etiologies. We thought less likely to be a non-optimal model, given that we've been able to use this in other sort of similar approaches. Then insufficient data, ending up with over 28,000 apical fourth chamber images in the training set, suggested to us that this was probably less likely. So we ended up not pursuing or validating it in the COVID-specific echo set because we didn't really expect that this would improve prediction versus our internal validation set. We ended up moving on to trying a different approach, which would be aimed at improving our diagnostic accuracy, though reducing essentially our patient population. So within the treatment diagnosis pathways, cardiac MRI plays a relatively large role based on the revised Lake Louise criteria for myocarditis. Essentially, if you have a T2 abnormality indicative of myocardial edema or inflammation, T1 type abnormality indicative of injury, the combination of those two in the appropriate clinical scenario is consistent with myocarditis. If you only have one, particularly the T2 criteria and appropriate clinical scenario, it may be consistent with myocarditis, and then supportive criteria can also be seen within the MRI. That being said, all this requires being in the appropriate clinical scenario. And so there is a degree of, I would say, subjective interpretation that is, whoever is reading the cardiac MRI would look at the clinical history of the patient. And for example, if they were somebody who's coming in for hypertrophic cardiomyopathy, they may fulfill the Lake Louise criteria, but if they have a story more consistent with hypertrophic cardiomyopathy than myocarditis, you wouldn't really grade them as myocarditis. So we end up needing to go through the actual reports of these patients, around 10,000 cardiac MRI reports in our data set. About 1,000 ended up having myocarditis mentioned within the report. We reviewed these reports, and around 250 of these reports were consistent with acute myocarditis. So we use that as the label for these cases. So an acute myocarditis diagnosis within the MRI report, echo within 30 days of the cardiac MRI, used a 1-to-3 propensity match data set using other patients who received cardiac MRI and had an echo but were not diagnosed with myocarditis in order to try and cut down on referral bias. We used the same essentially model pipeline and got sort of similar labels. So one issue that we sort of ran into was because we are a, I would say, large, significant imaging referral center for cardiac MRI, not all these patients had follow-up or had echoes or other testing or other notes within our chart. We only have around 100 unique patients with myocarditis with around 200 total echoes within 30 days. We did end up testing essentially echo time intervals from 30 days around the cardiac MRI, 90 days around the cardiac MRI, and 365 days around the cardiac MRI, mainly because for the most part, when a cardiac MRI is performed, it sort of indicates a clinically significant event. That is, you don't get referred to a cardiac MRI for simple screening. Typically, they'll have a specific issue that they want to look into, and they'll be referred for it. So we found that the 30-day time interval was the most appropriate. Also, the fact that the inflammation in myocarditis may resolve, but non-ischemic scar patterns may be left. We did sort of adjudicate those. The cases that had reports of possible prior myocarditis, we tried testing with and without it in the data set. Ended up essentially going with echo within 30 days of MRI diagnosis, only acute myocarditis, not using those possible prior myocarditis cases versus no myocarditis matched on age and sex within folks who received cardiac MRI. Ended up with around 4,000 apical fourth chamber images and validation AUC of 0.72, so not much better than our other approach. Once again, we went back to the drawing board to think about why this was happening. We would assume, given the sort of higher degree of reliability of an MRI report diagnosis of myocarditis, meaning that somebody reviewed the chart, reviewed the images, and said myocarditis versus the ICD codes, which may be less accurate, the AUC was still not sufficient for really anything clinically meaningful. Once again, we considered the potential causes. Still, it's possible that there's no signal for this diagnosis in the echo. We were less suspicious of inaccurate labeling, given that I looked at every single one of the reports and adjudicated them personally. We thought that probably still not suspicious of a non-optimal model. Our data set size was a lot smaller in this, and so insufficient data may be possible, that some balance between inaccurate labeling and insufficient data, which caused similar AUCs in both the first pipeline, the second pipeline. This started to make us, I think, more concerned that there may be not really any signal for diagnosis in echo. And so what we want to do next is we want to break the results or sort of the factors down to its component aspects. That is, if you think about the modified Lake-Louise criteria, we're depending on, say, T2-based abnormalities. So can echo predict a T2-based abnormality? Can echo predict a T1-based abnormality? Can echo predict late gadolinium enhancement or pericardial enhancement? Additionally, we included wall motion abnormalities, so presence or absence of wall motion abnormalities, and what the ejection fraction on MRI was. And we included that because those are things that we would definitely expect echo to be able to do. So it provides a little bit of a gut check to make sure that there isn't just something completely wrong with our pipeline if we don't get any ability to predict these. And similar to the results before, particularly the prediction of either abnormal T2 times or a linear regression-based prediction of the actual T2 time number had essentially no predictive value, R-squared of 0, and minimal binary predictive value for T2 times, which are associated with inflammation. Very limited ability to predict ECV abnormalities. Similarly, T1 and LGE, not great prediction. Pericardial enhancement, not great prediction, but wall motion abnormalities were very, very strongly predicted by the model as well as the LVEF. So overall, unfortunately, our AUCs, our prediction, our internal validation models of ICD-based myocarditis and MRI-based myocarditis, and honestly, MRI subcomponents that would comprise myocarditis-based diagnosis suggested probably insufficient signal. We are suspicious that this is an inability of, or essentially a lack of information within the echo videos to sufficiently associate with MRI findings, inflammation, things like that, particularly since the models were able to identify things that we were expecting to be detected. So could it be possible that some issue with balance of accurate labeling and ICD diagnoses and sample size issues in the MRI diagnoses combine to cause issues in both of these? Yes, it's possible. The sort of more parsimonious explanation would be that sort of at this time, there's probably insufficient true signal in the echo diagnose myocarditis. We had been relatively comprehensive, I would say, about different types of labeling schemes, around 150 different training runs for this study. And, personally, it's a little bit surprising with all the hype around deep learning. It sometimes feels like deep learning can predict anything. However, I do believe in the rigorous manner in which we ran these studies. We would be able to, I think, potentially rule out inaccurate labeling or data set sizes if we were able to find other data sets to train on. And we're still thinking of ways to improve the labels or maybe a different model approach, although we're less suspicious about the model being the root cause of why this was not working. We'd like to acknowledge this group for the support of the study, as well as other members of the lab who helped support this work. The folks in cardiac imaging who helped generate the cardiac MRI data, as well as our other collaborators and mentors. And so take-home messages from this myocarditis diagnosis is it's an issue. It's clinically challenging. If you come up with a good way of doing it using not biopsy, invasive imaging, and cardiac MRI, that would be certainly useful. We spent a lot of time with label design, data cleaning, which is a critical part of deep learning model training. And currently, we think probably echo is insufficient to identify myocarditis and multiple other factors on cardiac MRI. So I'll stop here and I'll take any questions. Thank you for your attention, and I appreciate your time.
All right. Thank you so much for this interesting presentation. Alan and David are now going to answer some questions. And there is one question from the audience, and maybe you want to mention something about the data that you use. So the question is, would there be a specific set of data on the MIDRC data repository that we could use to replicate what was done? So maybe you can say a little bit about your data, and then I'll chime in about the MIDRC aspect of it.
Yeah.
Perfect. Do you want to take this or should I take this?
Sounds good. Excellent presentation, and Alan led this project. We're very excited for kind of what MIDRC is doing. Our prior data sets have all been housed in the Amy Center with Kurt, given that they were Stanford data sets. But for ongoing projects as well as NIH-funded projects, we do hope to put everything, and to the extent possible, by our institution on MIDRC.
All right. Yes. Thank you. So, I mean, it should be noted that no, the answer to the question is not yet, but soon, hopefully. Now that we are moving away a little bit from acute COVID, we're ingesting data from different imaging modalities such as MRI, ultrasound, and also moving to other body parts. So far, it's been mostly chest, but now we are seeing brain images, cardiac, and also we're hoping to ingest cancer-related imaging soon as well. So that's hopefully soon. Okay, so there are no questions at this time in the Q&A. So I have some questions. So in the beginning, you mentioned that biopsy is not perfect, right? There's localization issues, sampling issues, and also a referral bias. So did you look into how your machine learning approach could be used as sort of a virtual biopsy, right? You could image the entire heart. So, but then since this is echo based, the question would be like, how repeatable is this approach?
Yeah, I think that this would sort of boil down to the point I was making about needing to create high quality labels and um, trying to come up with an idea for how we would um, create some sort of localization approach that would correspond with high quality like biopsy results is relatively difficult. That is, with endomyocardial biopsy, there's not really a recording of exactly where in the RV septum they biopsied the patients. And so trying to associate that, I think would be difficult, I would say.
Yeah, and going off of the idea of digital biopsy, there's already a growing body of work for radiomics in ultrasound and echo as well. And similarly, some of our prior work have focused on digital biopsy for cardiac amyloid, where we're using echo video to identify signals that might not directly correlate with the pathological biopsy, but very much strongly correlate with the diagnosis of cardiac amyloid. I think those are pieces where I think are exciting and still very much limited in terms of the upper bound based on sample size.
Okay, thank you. So there is a question from an audience member. I'm not sure who can answer this best. So the question is, how can we build digital literacy and data readiness capacity in underserved populations?
I would say this is an excellent question, and maybe I'll take this one. Broadly speaking, Alan and I are both cardiologists. We look to radiology as a place where I think that is very much the forefront of this. I think that there in pathology, limitations in terms of digitizing slides. In cardiology, I think that their standards for EKG are not consistent across vendors. But the DICOM standard, which also is used for ultrasound, is an area that there has tremendous value. The fact that there are PACS systems and VNAs builds in a lot of the underlying infrastructure required to analyze and process images at scale. And really, I think that it's very much, I think, our colleagues in radiology that's at the forefront of this. It is, I think the second piece of that question is also resourcing, as any healthcare center is constrained because all imaging is obtained for clinical indications, but it's an area where hopefully more resourcing and more resources can provide more opportunities to use bigger data sets.
Okay. Do you have anything to add, Ellen, or?
Yeah, I mean, I think that uh, the there's been also a democratization of the ability to use computer learning and deep learning. One of our sort of star lab members is basically self-taught, and so I think that there's more and more growing resources out there. We we would also want to emphasize that this concept of external validation, particularly external validation in, say, underserved populations or populations that may have different patterns, different diagnosis disease patterns than, say, at Cedars would be important. And so sort of keeping in mind the clinical applicability and external validation, I think is important as well.
Okay. I actually have one that's a short question, a little bit narrower than the previous question. So you mentioned earlier on that there are different forms of myocarditis. You have acute, this is not my field of expertise, but there are like 5 different kinds or something like that. So and they have each unique challenges, and I assume different presentations, right? So could that be a factor into why your model didn't perform as well as you were hoping?
Yeah, it's definitely possible. There are myocarditis is a little bit of a difficult area that there aren't. I guess there was a European myocarditis specific guideline 10 years ago. There's been some guideline consensus statements within the past few years. Most recent actual discussion of it is like Japanese societal guidelines. And um, the sort of terminology of myocarditis just refers to myocardial inflammation causing injury. And this can be infectious, viral associated, infectious, non-viral associated. It can include autoimmune causes. It can be, which sort of break down into uh, lymphocytic, eosinophilic, giant cell. Sarcoidosis is also somewhat under the larger umbrella of myocarditis. There's strange variants that are actually associated with celiac disease. Um, it's a pretty heterogeneous group, and then there's diversity in presentation that you can have. Essentially, subclinical myocarditis. You can have acute infarct-like myocarditis. You can have chronic myocarditis, which leads to heart failure. You can have acute fulminant myocarditis. And so would we expect these to appear differently on echo? Yes. Would they all have some degree of inflammation associated with it? Also, yes. And so I think that the fact that we really got no signal for T2 prediction using echo suggests that it isn't just that, that we really are having issues identifying myocardial inflammation.
Okay, unless anybody can type really quickly, and there are no questions in the Q&A at this time. So I would like to thank the speakers once again for their very interesting presentation and questions answering, and the audience for their participation. So I hope to see you all during our next MIDRC seminar next month, February 20th, I believe. So thank you very much. Bye-bye.
Thanks, everyone.